fibroids, and fibroids are more frequently found in African American women, also Asian women. Symptoms can vary. So some women will say, I don't have any symptoms. Some will say, my only symptom is pelvic pressure or that I look pregnant. And then some women will have pretty significant pain and or bleeding. Infertility can be another symptom, or pregnancy loss. Best way to diagnose fibroids, good thing about fibroids is they're easily seen on imaging. Physical exams are not helpful, right? Because we have, women of all shapes and sizes, and sometimes, they're difficult to feel on exam. Ultrasound, however, is the great, cheap, not super invasive way to diagnose fibroids. It can a lot of times be done in the OBGYN's office, and it pretty much can identify fibroids and measure their size. It may not be exact in terms of knowing how many fibroids, but it gives you kind of a general idea. MRI, often not needed, but can sometimes be helpful if we're looking for other conditions such as adenomyosis or endometriosis of the uterus. Treatment options, all right? So there are some treatments that are going to address symptoms. So if, let's say, you have abnormal bleeding, your OBGYN may recommend birth control pills. Doesn't mean that the fibroids will actually go away with birth control pills. Again, it's just mostly treating the symptoms. And so eventually those birth control pills may not be effective, or maybe they don't address the pressure symptoms or the frequent urination. Uterine fibroid embolization is one of the treatments for fibroids. However, you have to be careful because it's not the right treatment for everyone, and we will go into the detail why and why not. Acessa is another procedure, often not covered by insurance. It's laparoscopy with radiofrequency ablation of the fibroids, also not always the correct treatment choice. And then there's surgical interventions like myomectomy, which is removing fibroids, or hysterectomy, which is removing the uterus and the fibroids. So this last is the surgery, right? And again, these can be done via various techniques, and we will cover that today. So medical management, again, birth control pills, IUD, implant, patch. So all of these really to control the symptoms, but don't address the actual fibroids in terms of shrinkage. Then there's medications like Orilissa, Myfembree, and Lupron, and those actually block hormone production and can cause menopausal symptoms, which is just one of the side effects of the medication. But the point is, again, the fibroids are not going away. They may stop growing while you're on this medication, but once you stop the medicine, the fibroids can continue to grow. It's not necessary to be on these medications prior to fibroid removal. So if, let's say, your doctor said, oh, your fibroids is very large, we want you to be on this medicine to try to shrink the fibroids, it's probably not all that helpful because, first of all, it may take months, 3 to 6 months to see any change in the fibroid size, and the change that you will see, it's going to be pretty insignificant. So if, let's say, you have a watermelon-sized fibroid, it's still probably going to look like a watermelon, maybe a slightly smaller watermelon. So it's a little bit of a waste of time. So it's not, most of the time, it's not the right option. So uterine fibroid embolization, or UAE, which is uterine artery embolization, same thing. So it's a procedure that's done by interventional radiologists. It essentially, what it does, it blocks the blood supply to the fibroids by injecting little particles that look like little fish eggs. And so here it's shown, it's done either through the groin, or sometimes they do it through the wrist. So they thread the catheter all the way to the blood flow to the fibroids. The downside of the procedure is that it's not for patients who want to conceive, okay? Because as a sort of risk or a side effect of the procedure, that in some patients it will affect ovarian function because it can affect the blood flow to the ovaries. So about 37%. So that's significant, right? So if, let's say, you're in your 30s, which at that point already there's some decline in ovarian function, you don't want to affect that ovarian function even further by doing embolization. Also, the fibroids are not removed. So if you have fibroids that are affecting fertility, just embolizing them is not going to change your fertility prognosis and can actually affect it negatively. And then in case of large fibroids, there's only minimal decrease in size. So if you're having a lot of pressure symptoms, so if you look pregnant, if your fibroids are very large, then embolization is again going to be a waste of time because they're not going to decrease in size to any great extent to where you would actually feel a difference. And also doing uterine fibroid embolization twice is not helpful because if it didn't work first time, doing it the second time is, again, a waste of your time. Assessa, so this is the laparoscopy with radiofrequency ablation. So typically it requires at least 3 incisions, and it's surgery because you're getting laparoscopy, but you're not taking out fibroids, you're not taking out the uterus, you're just trying to sort of kill the fibroids. The fibroids are not removed. It's not effective for large fibroids, kind of same idea as the embolization, right? So this is very similar to the embolization, is that you're trying to kill the existing fibroid. If it's very large, if it's already degenerated or dead fibroid, you're not going to see any change. And then the many insurance plans do not cover it, so you're going to end up paying for it out of pocket. So again, not a great option for someone who either has big fibroids or whose fibroids are impacting fertility, because remember, those fibroids are not removed. So if they're impacting fertility before the Assessa, they'll still be impacting fertility after. Myomectomy, so this is fibroid removal, right? So we're preserving the uterus, we're taking out the fibroids, and those are procedures that can be done via various incisions and techniques. So the traditional open myomectomy usually requires like a C-section scar, or in some cases a big up and down incision, depending on the size of the fibroids and depending on who's doing the surgery. So this is a traditional surgery that's done by most OBGYNs. And so if you go to an OBGYN and you have big fibroids, this is the procedure they would recommend. Robotic myomectomy, which means using the robot or a special equipment or machine that helps the surgeon remove fibroids using smaller incisions. The downside of that is, there are multiple incisions. This is a belly button here, so they're located in sort of a semicircle around the belly button. The procedure typically takes a longer time to do, and it's limited because if there are numerous fibroids, or if there are a lot of fibroids that are deep inside the uterus, with this procedure, those fibroids may not be removed. And then the LAAM approach, which is a procedure that we do, it stands for laparoscopically assisted abdominal myomectomy, is kind of a hybrid between the two. So you have a small open incision, a bikini line, and then a laparoscopic incision at the belly button. So this is a technique that we use, and I'll talk to you more about that. So the LAAM, 2 incisions. So why is it best to do this procedure if you want fertility? Because you're preserving the uterus, right? And you're actually removing the fibroids that may be causing a problem, not only with bleeding, but with your ability to get pregnant. You get immediate results, right? So once the fibroids are out, your periods will improve, your pressure symptoms, your frequent urination will improve. Then you do have to wait about 6 months for the uterus to heal before you can try to get pregnant. But it's an outpatient procedure. There's no hospital stay, and your recovery is about 10 to 14 days. So it's a very good procedure. If you have fibroids that are deep inside the uterus, those can be removed. If you have multiple fibroids, those can be removed. So the location and the number of fibroids are not a problem for this approach. Comparing it again to the robotic or open or conventional laparoscopic myomectomies is that the LAAM is just more versatile. So there's no hospital stay. It's a shorter procedure. Also, so you're not under anesthesia for as long of a time. And of course, with open procedure, the problem is the 6 to 8 week recovery, which with the LAAM is only 10 to 14 days. So it's shorter recovery, outpatient. Now, what we did was in 2000, when was it? I think it was between 11 and 13, we did a retrospective study. So meaning that took all the surgeries that were done within those 2 years at a single hospital, at Holy Cross Hospital, for fibroid removal. So not only the LAAM procedure, but all fibroid removal surgeries. So it was about 1,300 surgeries by various doctors. We got rid of the ones that were done by inexperienced surgeons because we didn't want to examine outcomes of an inexperienced surgeon, because typically those surgeons will have not as good as outcome, and it's hard to compare procedures, techniques versus actual surgical skill. So we took high volume surgeons and compared the LAAM, the standard, the robotic, and the open abdominal myomectomies, right? Just to truly examine the technique itself and see what sort of better for patients. Oops, what happened? Oh no, what happened to my, I'm missing a slide on the results. Okay, well, I'll tell you, I'll tell you what we found. So we found that there were actually better outcomes with the LAAM procedure. There were shorter operative time, okay, because with the robotic surgery, with the standard laparoscopic surgery, it takes longer to perform the procedure because of the technique. Again, it could be a very skilled surgeon, but the robot and the standard laparoscopic approach doesn't allow the surgery to be done as efficiently. There was also a higher rate of converting to open surgery, right? Meaning that they would start out doing it laparoscopically, but then because of the number of fibroids or maybe because of excessive bleeding, they had to convert to open. And then the complications like infection or longer hospital stay or blood transfusion was lowest in the LAAM group, and it was actually highest in the abdominal group, abdominal myomectomy. So if you're interested in looking at this article, this was actually published in the JMIG journal, which is a pretty big journal on minimally invasive gynecology in 2018. So you can kind of check out the outcomes. All right, so this is a true patient story. So this is kind of giving you an example of how fibroids may present, and you may relate to this. So this is somebody who was 30 years old and presented with kind of pretty debilitating pain, and which brought her to the ER, right? So she had severe pelvic pain. They did an ultrasound, they did a CAT scan, and the only thing that was found was a fibroid. And they told her, okay, you probably have a degenerated fibroid, which is a fibroid that's outgrown its blood supply, and now it's dying and causing a lot of pain. So local doctors recommended her to have open surgery. She traveled to the DMV area from another state to have the LAAM procedure, which is the laparoscopically assisted abdominal myomectomy, right? So this is the approach that we use for the LAAM procedure. We use small incision. We do not use the morcellator. So the fibroid is cut by hand to avoid small pieces dropping into the pelvis. And this makes the surgery very efficient. The incision is kept small, even though the fibroid is large. Now, why wasn't a UFE a good option for this patient? Well, first of all, the patient desired fertility, right? She was only 30 years old, and it was a pretty sizable fibroid. So we don't want to do a procedure that actually doesn't remove this fibroid. And then the fibroid was already degenerated or dead. So you can't, even if you block the blood supply to this fibroid, it would do absolutely nothing, right? Or if you did the Acessa, it would do absolutely nothing. It's already a dead fibroid. It's just sitting there causing pain and occupying space that's needed for fertility. So the only treatment option for this patient was to remove the fibroid, right? And the LAAM approach was a perfect option for her because she could go home. She could leave the surgical facility the same day and then travel back home 2 to 3 days later. Another story here, a 33-year-old from Haiti, very large uterine fibroids. She did not have access to good medical care, and so she was here in the US, staying with her family. Her symptoms were abnormal bleeding, and she was having a lot of discomfort, a lot of pain because her fibroids were so large. She was having difficulty, eating and moving around. She had actually a pelvic MRI that showed multiple very large fibroids. The largest one is 21 centimeters, which is very, very big. It's a watermelon size. So she had the LAAM procedure. Again, 2 small incisions. She left the facility the same day. And this is what we found, right? So this was the very large 21 centimeter fibroid. And then she had a bunch of other fibroids, right? So she didn't just have 3 fibroids like the MRI had shown. She also had a lot of other fibroids, including some very small ones. And then the pathology showed 3,700 gram specimen. So this is all just fibroids, which is 8.2 pounds. So that's her weight, she was probably only 120 pounds, right? With 8 pounds of it was the fibroids. So this was a great procedure because the only alternative for her would have been a big up and down incision. So this was great because it gave her a very quick recovery, and she got to preserve the uterus. Again, was UFE or ASESA an option for her? No, because first, she desires fertility. And then second of all, these are giant fibroids. The UFE or the ASESA would do absolutely nothing to them, right? They would stay giant, and then she would still end up having the fibroid removal surgery. So any questions before we move from the myomectomy or the LAAM procedure?
That's great. We have 2.
Okay.
Does size matter for LAAM?
Yeah, so as you saw, size doesn't matter for LAAM. What matters is that, what kind of shape is the uterus going to be for fertility, all right? And that's the main thing with delay in care, because surgery is not magic, right? So we're dealing with already very abnormal and a lot of time damaged uterus. We can remove the fibroids, right? And then sort of reconstruct the uterus back together. But a lot of times when there are that many fibroids or they're that large, they've already caused so much damage to the uterus that fertility may not be a viable option. So yes, size doesn't matter for LAAM, but if you're looking for fertility outcome, there's not going to be a surgical option at all that is going to guarantee that fertility will be an option.
So one more question. What if a fibroid, oh, I just lost my track. What if a fibroid is attached to the vein?
Well, fibroids all have blood supply. Yeah, so there's not a fibroid that's not attached to a blood vessel, so that's not an issue. I mean, that's what a fibroid. For any tumor to grow, it has to have blood flow, so that's normal.
I have been suffering. This is the same person who asked the first question about the size of a fibroid. I've been suffering for 14 years with 3 grapefruit size fibroids. I don't believe in blood transfusion. Can I have LAAM without blood transfusion?
So it depends on the blood count. What we do is we use a cell saver. And the cell saver is a machine that we use during the surgery. If there is excessive bleeding, we can actually take that blood and it gets processed through the special equipment. And then we can actually get that blood and administer back through the IV. There are, certain caveats to that. So for example, if your blood count is already very low, obviously we can't give you blood that you don't have. So in that case, immediate surgery may not be an option. If you don't accept blood transfusions, you may need to go through iron infusions to increase your blood count, so that way it's safe for surgery. So, and LAAM is not the only procedure. So any surgery, right? So if your blood count is extremely low, and again, you don't accept blood transfusion, a surgery may not be an option for you at all right now, until that blood count is improved.
I believe we're good to go now. We can proceed. Okay.
All right, perfect. All right, so if you are not desiring fertility, and you have fibroids, or maybe you have other conditions that may require a hysterectomy, dual port may be a good option for you. So dual port is removing the uterus using small incisions, 2 small incisions, and it uses advanced techniques such as retroperitoneal dissection. So essentially what that technique does is it helps minimize complications, right? So excessive bleeding, injury to ureters or bowel or bladder. So these are some of the potential complications of surgery. And so using this technique, it decreases those risks. So again, if somebody who doesn't desire fertility, right, have symptomatic fibroids, recovery is 7 to 10 days and it's outpatient. So it's great because you don't have to worry about staying in a hospital, and it's a quick recovery, getting you back to kind of your normal life. It's better than a CIGC and UFE because you're actually definitively solving the issue of fibroids or abnormal bleeding. With the CIGC and UFE, remember the fibroids are not removed. So if you have bulk symptoms like frequent urination or lower back pain or pelvic pain or abdominal protrusion because of the large fibroids or abnormal bleeding, all of those things are addressed with removing the uterus. All those things will not be addressed if you do a CIGC and UFE. And then the fibroids can't come back. We do a partial hysterectomy. We keep the cervix and the ovaries. So that makes it sort of more of a what's called a functional hysterectomy. So it means that you're preserving the pelvic floor, you're preserving the vaginal length, and you're preserving your hormone production. So everything will stay the same. The only thing that will be different is that there will not be any more regular periods. And then all the, the symptoms that you're trying to treat related to fibroids will go away. How is it different from standard laparoscopic or robotic or vaginal hysterectomy or abdominal hysterectomy? So why is it different from other types of hysterectomies? Well, it's fewer incisions. There's less bleeding. There's shorter operative time, right? So instead of being under general anesthesia for hours, most of the dual port hysterectomies can be done in an hour or less. There are fewer complications because of the retroperitoneal technique, and it's a faster recovery, and it's outpatient. So again, you don't need a hospital stay. You don't need hospital at all, right? So smaller incisions, fewer incisions translates to less pain. Again, if you want to kind of dive deeper into the differences, we published another paper that was similar to the LAAM paper. This was published in 2019 in the Journal of Obstetrics and Gynecology. And again, we looked at all the hysterectomy procedures. So it was 2,600 patients done at a single institution between 11 and 13, and we compared all of them, and we saw really significant differences with the LAAM approach, with the dual port approach. So here's the tables. So with the dual port hysterectomy, for example, fewer incisions, right? So most patients only required 2 incisions, as opposed to robotic was with the most incisions. Shorter operative time, 62-minute average time for the dual port hysterectomy versus all the other hysterectomies required significantly longer time. Complications. There were fewer complications, intraoperative, for example, excessive bleeding, and postoperative complications like infection. So there were fewer complications with the dual port hysterectomy, which is the yellow bar. And then the size. So we actually removed larger uteruses using our technique compared to other techniques. So it's a great procedure. with a shorter recovery, fewer incisions, and it really can address even very large fibroids. So true story here, 40-year-old with 30 centimeter uterus with multiple fibroids, largest 15 centimeters, so very large. And symptoms, constipation, and kind of pain attributed to constipation, regular periods. So this is somebody who doesn't actually have abnormal bleeding, but has very large fibroids. And most of her symptoms are what's called bulk symptoms, so pressure from just having very large uterus. And she's noticed, of course, large belly for several years, doesn't desire fertility, and decided to go with the partial hysterectomy because she didn't want fibroids to come back. Somebody who's 40 years old, the likelihood of fibroids coming back is very high, right? Because she's not close to menopause at all. And we did a functional hysterectomy, right? We preserved the cervix to preserve the vaginal length and the pelvic floor support, and we kept the ovaries for hormone production. So this is after the uterus had been removed. This is the ovary on the right. This is the ovary on the left. And this is the cervix. This is cervix kind of in the background. And this is everything that was removed. So this is a large uterus, 2,400 grams, which was a little bit over 5 pounds. All right, so this is, again, outpatient, right? She was able to go home the same day, and recovery 7 to 10 days. Great procedure. And she avoided open surgery. This is another example, 46, who actually had uterine fibroid embolization in 22, and very large uterus, right? Watermelon size, 29 centimeters or 11 inches, sort of similar to the last example, had multiple fibroids. 2 years later, no change in size despite UFE, right? So this was a total waste of time. We decided to, proceed with removal of just the uterus, keeping the cervix and keeping the ovaries. This was UFE particles, right? Little beads, fish eggs looking things. This is the uterus with mostly fibroid tissue, and it's all degenerated. That's why it's so kind of whitish in color. Over 5 pounds, right? So similar to the other case. Again, this patient kind of, right, for the last 2 years, well, probably more, right? Because she already had a big uterus prior to that, but essentially since the treatment, nothing changed. So it was not the right treatment option. So another reason to really ask questions in terms of expectations, and we'll go into that in a minute. So again, comparing hysterectomy versus excessive versus UFE, biggest thing, bulk symptoms, okay? So if you have a big uterus that's causing pressure symptoms, UFE and excessive is not going to give you the results that you want. Abnormal bleeding, maybe, for both UFE and excessive may help you with bleeding, but not with bulk symptoms. So if you're looking to kind of take care of everything with one procedure, then you should consider a partial hysterectomy. Any questions?
We've got a few.
All
Does
right.
DualPortGYN cut the abdomen?
So it's just small incisions. So let me go back. So right here. So yeah, you're going through the abdomen. Of course, it's not a vaginal hysterectomy. So there are abdominal incisions, but they're very, very small incisions, with minimal pain and quick recovery.
And I guess we can stay on that page again, because there's a question about LAAM. What is the difference between LAAM and a robotic surgery?
Yeah. So with robotic surgery, the robot uses the machine that's then connected to what we call ports. So these are ports through which instruments are inserted, so long, thin instruments. So the robot arms are connected to these ports, and then the surgeon sits at a console away from the patient and controls these robotic arms remotely. Because of the way the machine is set up, it requires certain placement of these ports. So you can't put them wherever you want. They have to be put in the semicircle in the middle of the abdomen. And there has to be a specific number of incisions. So that's one of the biggest differences is that the number and the placement of the incisions is different. With the LAAM procedure, we put them kind of very cosmetically hidden. One can be in the belly button. The size of the incision can be smaller because the robotic ports are bigger in diameter because of a larger camera. They do require a certain size incision. With the laparoscopic, with the LAAM approach, it can be a smaller belly button incision. The bikini incision is in a sort of, again, a cosmetically located, and it's typically 1.5 to 2 inch incision. And you don't need then multiple incisions in the middle of the abdomen. The duration of the surgery, because of the technique, the LAAM technique is much more efficient. So it allows us to remove more and larger fibroids in a shorter period of time. So the recovery, again, that surgical time is going to be less.
How is it, just a few more, how is LAAM better than high intensity frequency ultrasound?
Yeah, so Acessa, right? So again, going back to the Acessa, the fibroids are not removed. So if you have, if we take our example of this patient, she would still be walking around with those same fibroids. So the LAAM procedure actually removes the fibroids. The Acessa does not remove any fibroids. They're still all there.
In partial hysterectomy, do you still need the fallopian tubes to help with egg production if you're looking to get a surrogate in the future? Are the fallopian tubes removed during the partial?
Yes, so the fallopian tubes are removed during a partial. Fallopian tubes do not have influence over egg production. They transport the eggs to the uterus. So if you don't have a uterus, you don't need the tubes. So only the ovaries are preserved.
All right, and one more. Can a woman carry an embryo after LAAM procedure?
Yes, I mean, that's the whole point of doing the LAAM procedure, right? So the LAAM procedure is a type of myomectomy, which we're taking out the fibroids and we're preserving the uterus, so that a woman can attempt a pregnancy. So yes, that would be the point of the LAAM.
Okay, so I know I see a lot of these questions that are coming in, and we can maybe revisit once we get through the last portion of our presentation.
Okay.
But keep them coming.
Yes, thank you. All right. So lastly, so how do we find a specialist? So let's say, yes, you're convinced you need fibroid removal surgery. You understand that UFE and Acessa is probably not the right thing for you. Well, first of all, why go to a specialist versus an OBGYN? So you want to go to someone who treats this condition surgically very often, right? So you don't want someone who occasionally does this in addition to other things. So you want the expertise in that specific condition, whether it's fibroids or endometriosis, because then you're going to be that surgeon will have those special techniques, right, and advanced procedures, and will be able to offer you better options. And with better options, there will be better outcomes, right? Whether it's less complications or better prognosis for pregnancy, right? So higher success rate, meaning fibroids are removed, the surgery went, uncomplicated, minimally invasively, and you were able to conceive. So that's would be considered success, right? Fewer complications. So there are many studies showing that high volume surgeons have lower complication rates. Is there a surgeon who never had a complication? No, because if they tell you I've never had a complication, that means they don't do a lot of surgery, right? So there are going to be complications. The more complicated the cases. So let's say if I only did very easy myomectomies, if I only took out fibroids that were small, or maybe only a few fibroids, yeah, most likely I would never have a complication. But if I take on more difficult cases, right, the 8-pound fibroids, or someone who's had multiple prior surgeries, or someone who also has endometriosis or scar tissue, right, the potential for complications becomes there. But overall, the higher volume the surgeon, the fewer the complications, because they know the technique, they've been trained and they know the techniques to lower those complications. And then there's reduced recovery times, right? So if you have open surgery, again, if you have complications, then your recovery time might be longer. And then there might be personalized care plans. So meaning that every patient is different, right? And everyone, although you can have 100 patients with fibroids, they have different situation. Maybe some, wants fertility, some don't. They've had, they have different fibroids, different locations, different size, different treatments that they've already had. So you can't really, it's not cookie cutter. You have to develop a plan that's going to suit each patient. Key qualifications: specialized surgical training and minimally invasive surgery, right? So just having an interest in surgery is not really, doesn't qualify somebody to be an expert surgeon, right? And that's difficult sometimes. So when you search online, everyone seems to be an expert, right? You look at people's biography and they all have interest in minimally invasive surgery. So sometimes you have to ask very specific questions. Mainly, how many surgeries have you done? Okay. Not years in practice. So that can be confusing sometimes. So you can have somebody who has, gray hair, and they look like, they've been practicing for 50 years, but does not mean that they're actually a surgical specialist, and definitely doesn't mean that they can do minimally invasive surgery very well, right? It just means that they've been practicing for a long time, but they could have been delivering babies for majority of the time. So first question to ask: do you deliver babies? Okay, basic, simple question. So if somebody who's practicing obstetric, which is baby delivering, I'm going to tell you that most likely this is not going to be a very advanced surgeon, because realistically, there's not enough hours in a day and in a week to be able to successfully perform surgery and enough surgery and also deliver babies, right? So if they deliver babies, that takes time away from doing surgery. So although they may be very interested in doing surgery, they're probably not doing enough surgeries on a regular basis. And so that brings to the next question: how many surgeries do you perform per week or per month? Okay, be very specific. Not like, don't ask how many surgeries have you done. They could tell you, oh, I've done thousands of surgeries, but how many surgeries? Actually, you can say, what days do you do surgery, right? So that's very specific. That's implying that they actually have specific surgical days each week, right? So it's part of their schedule. It's not an occasional thing, and it's not like, well, it depends how many surgeries I have or how many patients need surgery. So that's, then we're getting into, well, maybe they'll do 1 day a month, or maybe they might have 2 days a month, depending on the volume, right? Versus a surgical specialist who does high volume surgeries, they're doing surgeries, that's part of their week, right? If you go to an orthopedic surgeon, they'll have surgical days, and then they'll have days that they see patients in the office. It's part of their schedule. It's a routine for them, right? So same thing. So what days do you perform surgeries? How many surgeries do you do each day? And then how often do you how often do you perform surgery? Same thing. So the day thing is just more specific. What percentage of your surgeries are done laparoscopically versus open? Okay, so that's another important question, because here you're trying to figure out, is this mostly an open surgeon, or do they do most of their cases laparoscopically? And then the second question: what is the likelihood that you will convert to open surgery, right? So they'll say, yeah, we'll try laparoscopically or robotically, but if it's, if we can't do it, well, we might have to open you up. So what is the chance of that happening, right? And then you can find out what is their training that they went through to be a surgeon, to be doing these surgeries, right? So again, just interest enough is not, just being interested in surgery is not enough, right? You do need the surgical training. So this is an example of delay in care, which we see like all the time. And sometimes could be patient choice, could be provider, could be a combination of things, but this is somebody who's 51 years old, all right, and she's had abnormal bleeding for a long time. So she had fibroids, she had hysteroscopic myomectomy, which means just removing small fibroids from the uterine cavity, and these fibroids typically cause abnormal bleeding. So that was in 2017, all right, so we're in 24, so 7 years ago. Then that didn't work. So she had endometrial ablation 3 years later, but that's burning of the uterine lining to treat heavy bleeding, abnormal bleeding. So that helped her for a short period of time, but then the bleeding came back. Then she had an IUD inserted, which migrated, means it didn't stay inside the uterine cavity. It sort of shifted because of fibroids. And so it was removed. So now we're in 23. So 6 years later, still dealing with abnormal bleeding. Then she was put on birth control pills. All right. So for last year, she's been taking birth control pills. So she reports bloating, pressure, fullness, frequent urination. So the typical symptoms of fibroids. Her ultrasound showed 17-centimeter uterus. So that's almost to the belly button, with a fibroid 10 centimeters. So that's the size of an orange. So obviously this was, I mean, for 7 years, this patient has had completely wrong treatment, all right? Very common. All of these are common treatments for abnormal bleeding, but clearly this was not the right thing for her because all she had was big fibroids. So no one ever addressed the actual fibroids. And the hysteroscopic myomectomy, of course, is not going to address large fibroids in the muscle of the uterus. So she finally opted for dual port hysterectomy. By the way, she was never against the hysterectomy. Those were just recommendations that were used to treat her previously by OBGYNs. And that's not uncommon. When you go to a doctor who doesn't do surgery, they're going to naturally recommend non-surgical treatments, but that might not be the right thing for you. So pathology is 746 grams, so that's about 1.5 pounds, right? And this is all that came out. So again, perfect example is that sometimes, if somebody keeps recommending treatments that don't work, it's time to change, right? Time to go to a person who will recommend the right thing. So you have to be your own advocate, okay? And you want to make sure that all of the procedures will address all of your symptoms. So that's another good question to ask. Are all of my symptoms going to go away, right? What am I treating exactly with this procedure that you're recommending? Is this best if I'm trying to get pregnant, right? What is the likelihood of needing another surgery? So can my condition return, right? Can fibroids grow back? And then if you're not able to do minimally invasive surgery, please refer me to someone who can. It's a completely valid question, right? So please always seek a second opinion. Don't think that you're gonna offend your OBGYN. You may have a very good relationship with them, but your health is #1 priority. So please take your time and find the right specialist. All right.
Thank you so much, Dr. Danilyan. This was amazing. I'm gonna share, I know I see all the questions. We're gonna be now going through those questions. In the meantime, while I have you all here, I'm sharing an evaluation form in the chat box. Please take a moment to complete this. I will also share this link in my follow-up email, which would also include a recording of this webinar. All resources shared, including the articles Dr. D talked about in the beginning. The slides also would be included, and a link to our website with tons of resources. So don't worry, we'll send this over to you for your review. So, but I do encourage you please to complete that evaluation form because it does really help us improve our programs. And so to take a moment to do so. So in terms of questions, we have, you can read through them and then, okay, great.
Yeah. So with the LAAM, is the fibroid broken up inside or outside the body? As I learned, when you break it up inside, pathogens or cells can spread. So as you can see by this picture, this is outside of the body. So the fibroid is actually cut at the surface of the skin, so it's not broken up inside the body. We don't use a power morcellator. You know, not pathogens are like an infection, but for example, let's say cancer, right? So if you had cancer cells, you know, well, if you have uterine cancer, you should not be having a myomectomy. So, but let's say if you're worried about leaving pieces of fibroid inside, then this approach would be the best option for you. What would you suggest for a pedunculated fibroid causing pressure, but not pain or change in menses, size approximately 3 by 7 centimeters? And then there's also ovarian cyst on the left, not concerned about fertility. Yeah, so it can be, you can either take out just the fibroid, and then the cyst, of course, can be addressed at the same time, or you can take out the uterus if you're concerned that other fibroids may grow in the future. So if you're not worried about fertility, then either a partial hysterectomy, which is a dual port hysterectomy, and then at the same time addressing the ovarian cyst, or a LAAM procedure. So yeah, both a great minimally invasive surgical option. I don't recommend uterine fibroid embolization because with pedunculated fibroid, typically that procedure is much less effective. And then of course you can't really address the ovarian cyst at the same time. Is it okay to leave the peduncular fibroid inside after it dies? I mean, yes, it's okay. The only thing is if it causes pain or pressure or any type of symptoms, right, then it becomes not okay. Also, sometimes with uterine fibroid embolization, especially for those pedunculated fibroids, there is a lot of inflammation, and so it leads to scarring. So a lot of times we see when we do surgery on a patient who've had previous embolization, those fibroids tend to stick to surrounding structures, and that can cause additional pain. So not ideal, but if it's a small fibroid and it's dead, you probably don't need to take it out. Why is it that some young women stop having menses after fibroid surgery? So if we're talking about a fibroid removal only, so if the uterus is still intact, then the periods should continue. So it's not normal not to have a period after a fibroid removal surgery. Now, however, you know, as you see, we take out really massive fibroids sometimes. And so with that, with surgery of that proportion, right, of taking out that many fibroids, that can lead to scarring. So the uterus, because it's, you know, been replaced by fibroids, and then again, you piece this uterus back together, the normal uterine lining may not grow. And so that can lead to scar tissue and lack of periods. So that would definitely need to be evaluated. Typically, 6 months after the surgery, we always evaluate the uterus for scar tissue, especially in a patient who wants to get pregnant. If fertility is not desired, then it's not, you know, it's not dangerous not having periods. It just means that there's scarring in the uterine cavity. Let's see. When you keep your cervix and ovaries in the partial hysterectomy, is there a chance for the fibroid to return the cervix? I've heard you can still have a period when keeping the cervix. Is that true? So cervical fibroids are much less frequent, but it's true there may be a possibility of a fibroid returning in the cervix, but it's extremely, extremely uncommon. So some patients, especially younger patients, when they keep the cervix, they can have monthly bleeding. It's typically very, very light because there's just not enough lining in the inner cervical canal to produce a sort of a full-on period. So most of the time, patients don't find that extremely bothersome. To resolve the bleeding completely, you would need to either have the cervix removed, or you could, you know, do hormonal management to sort of minimize the spotting or the bleeding. But most of the time, it's very light, and it may not even be every month. Why would someone choose LAAM versus vaginal hysterectomy? So LAAM is a myomectomy. So LAAM is the fibroid removal surgery. It's not a hysterectomy. Um, if the question is more like, why would somebody choose laparoscopic hysterectomy versus vaginal hysterectomy? So not every patient is a candidate for a vaginal hysterectomy. Vaginal hysterectomy cannot be done on very massive uterus, like an 8-pound uterus can't be removed vaginally. Patients who've had prior multiple surgeries, especially C-sections or other surgeries, should not have a vaginal hysterectomy because the risk of bladder injury is very high. There's actually more pain associated with vaginal hysterectomy. So vaginal hysterectomies are less frequently performed, especially if we're dealing with large fibroids. Is in the diaphragm, is that, oh, sorry.
I think in this picture is what
Oh,
she's referring
diagram.
to, like diagram, yeah.
Oh, yes. In
Yeah.
the diagram is the hole in the belly button or abdomen or sorry. Okay, yeah. It's not in the belly button, it's just above the belly button. So it's the upper aspect of the belly button. And then the second one is in the, I thought I had a picture somewhere. And the second one is in the bikini line. Yeah, so it's right.
Also, if
Okay.
you're interested in like actually seeing a video of Dr. Danilyants doing the surgery and where the holes go or the incisions go, you can also go on our web on our socials, and we have a couple of videos on that. So
Yeah. And then the next question, what makes it possible to have a successful vaginal delivery after myomectomy? Okay, so that depends on not the technique of the fibroid removal, but where the fibroids are located within the uterus. So if the fibroids were removed from the muscle of the uterus, let me see. Yeah. Okay. So here's fibroids, right? So let's say a patient only has this fibroid here. We remove it. We didn't even need to cut into the muscle of the uterus, which is this red part here. This is the uterine cavity. So if that type of myomectomy was performed, there's no issue with attempting a vaginal delivery. If we're talking about removing intramural fibroids like these, so we actually have to cut through the uterus to get to the fibroid, all right, then a vaginal delivery should not be attempted because as the labor starts and the uterus starts to contract, this is uterine muscle and it contracts, the uterus can rupture. So if you had intramural fibroids or fibroids removed from the muscle of the uterus, then you should not try to have a vaginal delivery. If this was just a hysteroscopic myomectomy where we went through the vagina and just removed a small fibroid inside the uterine cavity, then the vaginal delivery is fine. Let's see. So it's not so much preferred method, it's safety, so it's not safe to attempt a vaginal delivery after myomectomy if the fibroids were removed from the muscle of the uterus. Are you put under anesthesia for the LAAM procedure? Yes, it's not local anesthesia, it's general anesthesia, so you're intubated. Is it okay to leave the fibroid not doing anything since it doesn't cause pain? Is the fibroid going to change much as I get older? What would you suggest for peduncular fibroid causing pressure but no pain? So this is the same fibroid, 3x7 with a cyst. Well, I mean, 7 centimeters is sizable, but I would say if it's not changing in size and you absolutely don't want to do surgery and you're okay with it causing pressure, then you can just leave it. Ovarian cyst, I'm not sure because different cysts can be of different cause, right? So there's cancerous cysts or tumors of the ovary. Sometimes imaging is not enough. So if this is a new cyst, I'm not sure if it's 5 or 9 centimeters, but if it's a 9 centimeter cyst, that needs to be addressed with surgery, at which point you may as well address the fibroid as well. So I would say it doesn't sound like conservative treatment is going to be the right option here. Yeah, so we're not located in Canada, but we're in the DMV and the New York, New Jersey area. So we do frequently treat patients from Canada who travel for surgery.
Yes, and I'll send all of the social website info in the follow-up. And I believe some questions that came through the Q&A, there was, what pre-tests are needed for LAAM, if there's a pre-test?
Pre-test, just just like for any surgery, depending on your medical conditions. So it could be blood work, if certain age or diabetes and heart conditions, we require EKG. So nothing special, just sort of routine preoperative testing.
All right, we are right on top of the hour, and I think we addressed all the questions. Dr. Danilyan, thank you so much for taking the time to do this presentation as always. And please, I did share the evaluation form again. I'll go ahead and complete that. It takes you a few minutes. We will share all resources discussed today. We are back again. So I know we took a month of a hiatus from doing this webinars, but we are back hot and ever. So we're going to be doing all the presentations in the coming months. So be in the lookout. I'll be sending out the next invitation very soon. I want to thank you all for being super engaging and for staying with us until the end. So it's been great. Thank you so much. I'll stay on a couple of minutes to help to just make sure that you have the link and you complete that evaluation. Dr. D, I think you can jump off if you like now. Thank you again.
I think somebody had mentioned that they sent 2 questions. What were those questions? I think you had told me before. I sent questions yesterday. Will you answer them?
Which questions? Okay, we have. I believe we have addressed most of the question I sent.
You asked them, yeah, because I think you said that you're going to ask me a couple of questions.
Yeah, so I can ask you some of the questions that came through. And yeah, if you have a few minutes, we can maybe address them.
Yeah.
So number 1, should I get an MRI to help with treatment plan?
It depends. So it may be helpful. Yeah. So typically we kind of on individual basis, sometimes we get an MRI. Yeah, absolutely.
Are the procedures performed under general anesthesia? I think we talked about that already.
Yeah.
What can remove fibroids besides hysterectomy? We talked.
Yeah. So it could be another option. Mm-hmm.
Why do some young women 20s to 40s stop menstruation after fibroid removal?
Yeah, so not normal. If the uterus was preserved, so that would be unusual to not have a period. So that should be evaluated for sure.
And the person is afraid of like a surgery basically, and so that I think you addressed it. Pros and cons of fibroid surgery, we talked about that.
Yeah, so, general surgical risks, and then fibroids can come back, right? So if you're just having, if you don't want the fibroids to come back, potentially considering, removal of the uterus might be a better option. And then we don't know what causes fibroids, so that's another question here. We know that they're estrogen-dependent tumors, so just producing estrogen, right, which is one of the hormones that's made by the ovaries, can make them grow or come back. And what are the percentage or risks of LAAM for women wanting to have babies in the future? Percentage risk of LAAM.
Okay. And
yeah, so there's risk. I'm not sure I understand the question, but so the risks have to do with the fibroids themselves. So where they're located, how many fibroids there are, and then in terms of the ability to get pregnant in the future after LAAM, again, depends on what condition the uterus is in, right? So if you have 50 fibroids, or if you have 8 pounds of fibroids in the uterus, that's not ideal. If you really want to preserve fertility. Again, yes, we can take out fibroids, but it's going to depend on where were the fibroids, how much they already affected the uterus in terms of the prognosis of pregnancy in the future. And then patient's age is also going to play a big role, whether or not there's endometriosis or other conditions that impact fertility.
All right. Would getting a partial hysterectomy worsen my menopause symptoms?
Say it again. Say it again.
Oh, would getting a partial hysterectomy
Yeah.
worsen my menopause symptoms?
Oh, it wouldn't worsen or improve. So menopause is decline in ovarian function. So by leaving the ovaries, they would just still continue to decline, right? So an option here may be estrogen replacement after the uterus has already been removed to address those symptoms.
And this is just the same person kind of with multiple questions. So do you have referrals for hormonal evaluation and support for pre and post-surgery patient care?
Yeah, so it depends. Again, we treat each individual patient differently depending on their situation and condition. So if they do need hormone replacement, we would, of course, address that as well.
Right, and I think we talked about it, but what impact does having prior UAE or embolization procedure performed have on a valuability of your surgical techniques on a post-menopause patient with light bleeding daily and weekly?
Yeah. So if somebody, well, first of all, if somebody is postmenopausal and they have bleeding, that needs to be checked because we want to make sure there's no uterine cancer, because uterine cancer can present as postmenopausal bleeding. And then as far as prior UFE procedure, yeah, I mean, we deal with patients post-UFE procedures all the time, right? Because at least 30% of those patients end up having a hysterectomy or some other type of fibroid surgery. There may be scar tissue that's found during the surgery, but yeah, that's not typically a problem. Yeah.
Perfect. I think we addressed all of the questions, and if we didn't get to them, we will just have Dr. Danilyants respond to them and send you in an email format. So we hope you enjoyed this webinar, and we hope to see you soon as well. All right, have a good one. Bye.
Bye. Bye.